Hi friends, in this series of respiratory system examination, today I will talk about palpation. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or company. Palpation is the tactile examination of the chest from which can from which we can elicit tenderness, asymmetry, diaphragmatic excursions, Crepitus, and vocal fremitus. Local tenderness can indicate trauma or costochondritis. Asymmetry and diaphragmatic excursion can be assessed by placing one hand posteriorly on each hemithorax near the level of diaphragm and palms facing anteriorly with the thumbs touching at the midline. When the patient inspires, each hand should rotate away from the midline equally. Unequal movement or a minute amount of movement indicates or a minute amount of unequal movement or a minute amount of movement indicates asymmetry and poor diaphragmatic excursion respectively. Crepitus is the sensation of crackles under the fingertips during the superficial palpation of the chest wall, and this indicates the presence of subcutaneous air, which is often associated with pneumothorax on the side of the abnormality. After superficial palpation, deeper examination of the lungs and the air spaces can be accomplished by testing for vocal fremitus. The examiner places the ulnar edge of the hand on the chest wall while the patient repeats a specific phrase, typically 99 or 123. The strength of the vibration felt indicates the attenuation of the sounds transmitted through the lung tissue. Areas of increased vibration or fremitus corresponds to area of increased tissue density, such as those caused by consolidation by pneumonia or malignancy. Overlying fatty tissue, increased air space as in COPD, or fluid outside the lung space may decrease the perceived fremitus. Coming to the palpation of the lower respiratory tract, how do we examine trachea? The normal length of the trachea is 4 to 5 centimeter above the suprasternal notch. Normally, the cricoid to suprasternal notch distance is 3 to 4 ring finger breadth, and it is decreased in COPD due to hyperinflammation. How do we palpate trachea? Keep the index and the ring finger of the right hand on medial ends of the clavicle. With the middle finger, trace the trachea from the above downward as shown in the picture. Then insinuate the middle finger between the trachea and the sternal head of the sternocleidomastoid and feel for resistance. The importance of this is the tracheal shift usually denotes the upper mediastinal shift. Oliver sign or tracheal tug sign. Here we stand behind the patient and hold the cricoid cartilage and give a slight upward thrust. The positive test is indicated by downward pull with each heartbeat, and it is suggestive of aortic aneurysm. Negative test is normal. False positive is seen in mediastinal tumor attached to the abdominal aorta, and false negative is thrombosed aortic aneurysm. Tracheal descent on inspiration, it is called Campbell sign. It is due to downward pull of the depressed diaphragm in long-standing hyperinflation of the lungs. Laryngeal fixation is seen in increased pressure on the cricoid cartilage due to inflammatory or neoplastic lesion in the mediastinum. How do we palpate the apical impulse? We just confirm the position of the apex and comment on the character. We have to watch for thrill or other palpable heart sound. Whenever there is shifting of the apical impulse, it indicates the lower mediastinal shift, and apex or apical impulse may not be felt or seen in respiratory diseases like emphysema, left-sided pleural effusion, and left-sided pneumothorax. So, what are the conditions where we see the mediastinal shift? If there is shift of the trachea to the same side, it is suggestive of fibrosis or collapse on that side. If trachea is shifted to opposite side, it is seen in pleural effusion, pneumothorax, tumor or mass. Usually, the pneumonia, COPD, asthma, bronchiectasis, interstitial lung disease, they don't cause any shifting of the mediastinum. How do we see the respiratory movements? For upper anterior chest, we examine it by placing the palms in the infraclavicular areas as shown in the figure. Look for supero anterior movement of the palms, and this examines the like the pump handle movement of the upper lobe. Lower anterior chest, here we grasp the side of the chest and approximate the tips of the thumbs in the memory area with a loose fold of skin in between, and we watch for separation of the thumbs and compare the movements with each respiration. It demonstrates like bucket handle movement of the lower chest. This is how we see the upper anterior chest and lower anterior chest. For upper posterior chest, we examine from the back by placing the hands in the supraclavicular fossa and watch for movement superiorly. And this demonstrates the movement of the apical segments of the lung. The lower posterior chest, here we grasp the sides of the chest and approximate the tip of the thumbs in the infrascapular area with the loose fold of skin in between, and watch for separation of the thumbs and compare the movement with each respiration. This demonstrates the lower lobe movement. This is the picture which showing the how do we palpate or we see the chest movements for anterior upper chest, anterior lower chest, posterior upper chest and posterior lower chest. For palpating the diaphragmatic movements, we place one hand on the chest, other hand on the abdomen. Normally, both hands are lifted during the inspiration. If the chest rises but the abdomen remains static, it is suggestive of abdominal pathology, which is fixing the abdomen. If the chest rises but abdomen retracts, it is suggestive of diaphragmatic palsy. How do we measure the chest diameter? The AP diameter of the chest is measured by using two cardboards. Here in the figure we can see we place one cardboard anteriorly and one cardboard posteriorly on the chest, and we measure it with a measuring tape. Normal ratio of anteroposterior diameter to transverse diameter is 5:7, and normal chest expansion is 5 to 8 centimeter in adults. It decreases with age. For example, a 60 years old person, it is for normal person it is 5 to 8 centimeter in adults, but in 60 years of the person we can take it as 3 centimeter. It can be considered as a normal. In patients with COPD and interstitial lung disease, the expansion is usually less than 1.5 centimeter. How do we see hemithorax expansion? We stand on one side and place the tape from supine to mid-sternal. Chest expansion should be assessed as the difference of the measurement between the deep inspiration to deep expiration. Increased hemithorax size with decreased hemithorax movement is seen in pleural effusion and pneumothorax. Decreased hemithorax size with decreased hemithorax movement is seen in fibrosis and collapse. Normal hemithorax size with decreased hemithorax movement is seen in consolidation. And examination of the spino-scapular distance, it is the distance between the spine and the scapular line. That is, scapular line is the vertical line passing through the inferior angle of the scapula. So The distance between the spine and the scapular line is the spino-scapular distance. Then we examine the spino-acromial distance. It is the distance measured between the spine and the tip of the acromion process as shown in the figure. Vocal fremitus, it is the sound which is produced by the vocal cords and transmitted along the tracheobronchial tree and heard or felt over the chest wall. Here we place the ulnar border of the hand as shown in the figure and on identical areas on the both sides of the chest. We ask the patient to repeat 1 1 1 and we feel the sounds produced by the chest. It is called vocal fremitus. It is increased in consolidation whenever there is large cavity in the lung, bronchopleural fissura, and this vocal fremitus is decreased in pleural effusion, pneumothorax, fibrosis, collapse, asthma, emphysema, and thick pleura. This is the place. This is the picture which is showing how do we check or what are the identical areas by which we can do the testing of vocal fremitus, and what are the condition in which it is increased and decreased. Tactile fremitus, these are the palpable adventitious sounds and they could be coarse crepitation or rhonchi. Friction fremitus is these include palpable pericardial rub or pleural rub, for example dry pleurisy. Coming to the tenderness, it is seen in patients with empyema, that is intercostal tenderness is seen in empyema, local inflammation of the soft tissue, osteomyelitis, rib fracture, costochondritis, Teat syndrome, tumor infiltration, amoebic liver abscess, and subphrenic abscess. These are the conditions where we can encounter tenderness while palpating the chest. How do we the detection of the subcutaneous emphysema? It is a spongy, crepitant feeling on palpation. It is due to injury to the chest wall, pneumothorax, or rupture of the esophagus, rib crowding, or intercostal widening. Here we stand behind the patient and place the fingers in the intercostal spaces simultaneously on both sides, and we observe the separation of the fingers. This is the picture. How do we see rib crowding or intercostal widening? We stand behind the patient and we place the fingers in the intercostal spaces and ask the patient to breathe in and out, and we can judge on both sides by placing the fingers in the intercostal space where whether there is a rib crowding on one side or other, or whether there is intercostal widening. We can compare the both sides. So rib crowding, the unilateral causes are atelectasis, collapse, fibrosis, pneumonectomy. The bilateral causes of rib crowding are interstitial lung disease and fibrosis. Fibrosis when it is bilateral. The intercostal widening, the unilateral causes are pneumothorax, pleural effusion, and bilateral causes of intercostal widening are emphysema. Albert Einstein has said, "Only a life lived for other is a life worthwhile." With this, I conclude my today's topic. In next video, I will talk about the percussion. Thank you. Keep learning.